Thank you very much. Well, lovely to be here and to have the opportunity to present on behalf of our iCASCADE team. So our team has been looking at the association between prescribing cascades and gender. So just to give you a little bit of context, because you may not all know about this, prescribing cascades basically occur when a drug is given to a person, a new medical condition or a drug side effect actually occurs, and it's interpreted as being a new medical condition. And then the person gets another drug, and on and on and on. So the example that we have here of a prescribing cascade on the slide is, for example, a person gets a diuretic, which is a drug, for example, that might be used as a treatment for hypertension, things that we just heard Louise talking about for her group. But sometimes related to a diuretic, you can get an elevation of one of your blood tests, and you end up with hyperuricemia and end up with actually gout. And people then start giving you a medication for gout because they assume that you've now got a new medical condition. So this is a sort of an example of how these prescribing cascades develop. And we now know that there's very many of them. And we're very interested in how gender, sex, gender, and age play into these prescribing cascade. And they're important. Putting on the far side, we have the piece about the economic repercussions. When you have people who end up on drugs that they don't need to be on, that's expensive because of the drug side effect of it. But it's also expensive because it can lead to unnecessary. Yes?
Paula, I'm afraid I'm sorry I have to interrupt you, but because we've lost your screen, so I don't know, somehow incidentally you must have pressed some button or something. Could you share your screen with us again?
It says I'm
We see
sharing.
you, but we don't see the screen.
All right, let me just try again.
Can you try to share again?
Yeah. I think Chloe's screen is there. That's what you're seeing.
We're seeing a screen with purple and pink.
Yeah, I think
Um,
that's Chloe's
oh, there we
screen.
are. Okay, so we have the presentation back, but it's not full screen.
Okay.
You're in notes view, Paula. You're gonna have to switch to presentation view.
Yeah, I'm just not seeing that. Okay, I'm gonna stop share. Let me just try again. Share screen.
Yeah,
And
getting there.
share.
We only need
Getting there. Okay.
we only need the full screen view and
Okay, I'm just looking for that.
bottom
View.
right.
Two tabs over under slideshow, Paula.
Okay, just sorry.
No. So you see review and then slideshow
At the
at the top.
bottom of your screen on the right hand side, normally you should have
There we go.
Yeah. And then click slideshow again. And then play from start. So the very first, you go down, and then go all the way to your left. Play from start.
Okay.
Yeah, very good.
Is that
We're
good?
there.
Okay, sorry about that.
No
All right,
problem.
so
Thank you.
we got to this part, right? So we
Yeah.
talked about prescribing cascades and how they occur. So we were very interested in how gender, sex and gender and age play into the idea of prescribing cascades, which are basically inappropriate prescribing. And it was interesting when we looked at some recent pieces, and they talked about how, while we're learning a lot about issues related to sex and gender, a lot of this information is seldom included when we're thinking about drugs. And so that area has often been left out. So it's important for us to think about that. So here's a picture of our iCASCADE team. We have an amazing, I would say that this funding opportunity has been an amazing opportunity to work with investigators from around the world, an opportunity I've never seen in any other funding that I've received. So here's our team members across the top. We have investigators from 6 different countries working with us, from the United States, from Italy, a large group from here in Belgium, from Israel, and as well as from Ireland. So we've been able to bring together a really diverse team that's all interested in drug prescribing and the issues around sex and gender. Now, there was 3 things that we wanted to do with our project. First off, we wanted to create an inventory of these prescribing cascades. I described one to you, but we know that there is actually more than 100 of these different cascades. The second objective was to compare the frequency of these prescribing cascades by sex and country in various different settings of care, and I'll talk to you about that. And the third was to explore how sex and gender is associated with the development and impact of cascades. So in terms of some of the pieces that we were able to do, we did create a very interesting piece that describes an inventory of prescribing cascades that are out there in the world. And we did this using a Delphi process and getting input from people from all of the countries that were involved in this project. The second objective, the work that we did here, I think is very interesting and relates to the presentation that you just heard. We were comparing sex, gender, and age using data that we were able to get from different settings of care and from different countries. So you can see here that we had data that was from the community, so population level data. We had also data that was from hospital settings as well as geriatric hospital settings. And we had data that was from long-term care, so a bit of a spectrum of settings. As well, we had, these were all secondary data sources, and we had some population level data, clinical trials data, and registry type data, and it came from all different countries. But it's interesting that no matter where we looked, we saw some similar results, and I'll show you some of those. So from a gender perspective, we found that some of these variables, the gender-related variables, were not purposely collected in these data sets. So we had, what was potentially available. We had no gender-related identity variables in any of the data that we looked at. But here's what we found. No matter which data set we looked at, women were more likely to have low income, women were more likely to have less education, and women were more likely to be widowed. All of these things would potentially disadvantage them. Look at some of our data sources. And here you can see on this side, this is data that comes actually from Canada, where we're looking at about 2.5 million older people. And you'll see that this piece over here is data that comes from the community setting. And we look at people who are given 8 or more medications. And we've divided it by those who are higher income and those that are lower income. What I want you to see is that if you have lower income, you're more likely to have more medications. And that's potentially, or could be potentially, inappropriate. You also see potentially the differences between women and men here. Women in the pink, men in the sort of the darker color. So for both women and men, you see the low income is really important. Going over to the far side here, looking at long-term care, a similar scenario that when you're looking at low-income people versus high-income people, you're more likely to have people using more medications if they were in the lower income setting. And, there's some potential differences between women and men. We also looked at the idea of a prescribing cascade. And here we are looking at a common prescribing cascades related to calcium channel blockers. You get these drugs, you end up developing some edema, and then you end up on a diuretic to treat the edema. So again, using data from Canada, you'll see high income and again, low income, and the pink is showing the women. And you'll see that again, in the lower income setting, people are more likely to have the prescribing cascade, which is in this case, a measure of inappropriate prescribing. And then similarly, we have data from Israel, and you'll see maybe not quite as dramatic, but when you get into the lower income group, again, these cascades are more likely to occur. And then you'll also see in the pink that there's a suggestion that they're more common in women than in men. We also, I think we saw that. We also looked at these cascades and what it means around marital status. And some of our data sets had marital status as a variable. So here we have the reportage data set that comes from a number of different countries. Again, here we see it's more likely in women than in men to develop a cascade amongst those who were not married. And then again, in another one of our data sets that looks at long-term care homes, women that were not married were the group that were more likely to develop these particular cascade. One thing I really want to show you here is the importance of age. And as geriatricians in this project, age is a very, very important factor in everything that we do. Here you see the age groups from 65 up to 85 plus. And what you'll see is when you look at this prescribing cascade, it's more frequent as you get older, I think dramatically so, you can see here. And you can also see that it's more frequent in women than in men. Now, this is just a crude measure of a prescribing cascade that we're using for these data, but I think it's important to point this out. And you'll also see again, the bottom for each of these age categories is higher income, above is lower income, and in each case, it's worse in the lower income setting. So a lot of different pieces happening here. We, as our team, created a very helpful module called What Gets Counted Counts. And it's to help people think about the importance of paying attention to sex, gender, and age in health research and how you would go about doing that. So here's some of our initial learnings. Prescribing cascades are well-defined indicators of potentially inappropriate prescribing, very important for older people because this can lead to harm. And our findings from different international data sets indicate that prescribing cascades occur in a variety of clinical settings and that there are differences between males and females. Women are more at risk, and older women, low-income women, and widowed women are groups that are particularly vulnerable. So here we have some questions based on this work. You know, why isn't that sex and age are not routinely considered? You know, we actually had data about sex and age in all the data sets, and it's the sort of thing that's not thought about and used routinely in research. And second, how do we look at gender when we don't consistently collect that data? So all the data sets that we looked at had potentially a measure of gender, but it wasn't done purposely, and it wasn't done consistently across the data sets. So when we think about gender, and you know, it's not just about individual data sets, it's a much bigger piece. You know, you can think about gender as it relates to countries, and we know that if it affects countries in different ways. There's data available to look at gender at a country level. For example, the OECD has created Gender Equality Index, which is helpful. You can think about it at a health system. You know, does a country, for example, have public health care available? Do they pay for drugs for older people? These are things that are important. And these things all layer on as we see over here. All of these pieces are important when you're thinking about gender. But a piece that we saw that was missing was physicians' decision-making process. So we went on to look at how do potentially unconscious gender biases impact physicians' prescribing decisions. This was a very interesting project that's still underway, where we've brought together different countries. So again, Canada, we have Ireland involved, as well as Italy, all collecting data. And we're collecting, we're using vignettes, telling people stories about prescribing cascades without using that word. And we're trying to determine, does a patient's gender affect their risk of experiencing a prescribing cascade? And does a physician's gender affect their prescribing decisions? So to do that, we have male and female physicians, and we have male and female patients in each of these different countries that we're evaluating. Now, the results are just coming forward, but we are finding some interesting things. One, for example, is that in Italy, it's noted that season comes up. People are interested in what season it is. And if it's the summer and it's hot, people are, more concerned about, for example, edema, and maybe what that means for women in particular. So unconscious, the things we're learning is that unconscious gender biases and gender norms differ by culture, country, and time. So we need to think about how can we make sure that they're always considered. So here are some of the challenges that we have. Data on sex and age are available in just about any kind of data set that we look at. And I would imagine that all of you would have that same experience with your data, but they're not consistently considered. So what should we do? Data should be disaggregated, analyzed, and reported by sex and age. That's something that we ought to be doing as a research community. A challenge. Data on gender-related sociocultural variables are really scarce, and they're not looked at uniformly. So what do we need to do? Gender-related sociocultural variables need to be included in research. And then finally, gender-related variables are not required in drug-related research. And I think we have a real opportunity here to require the inclusion of sex, age, and gender-related sociocultural variables in funding for research and drug development. So these international collaborations are really important to accelerate knowledge. We found that different countries have varying levels of development in the idea of sex and gender in their research. But these international collaborations provide that opportunity to bring together experts in a similar field, but with very different perspectives and knowledge of sex and gender-related issues. And by doing this, I think we're really able to advance our understanding of the topic. So here are some of the papers that we've published, starting early on when we were identifying the different cascades, to thinking about work about inappropriate prescribing and opportunities for deprescribing that puts in place a gender lens. And I'll just end with some quotes from some of our team members, just saying how important this funding opportunity has been to us, really around the world, and how unique it's been. And I'll just read this one for you, which I thought was really quite good. It says 1 + 1 = 3, meaning that by involvement in this international expert network, the expertise and experience of each of us has increased, which has on its turn resulted in a productive collaboration with excellent output. So that's a quote from our colleague as part of this project, Mirko Petrovic, who's actually here in Belgium. So with that, I want to thank you for the opportunity, and it's a pleasure to be able to present to you today, and to thank you for your support of our project.